So thank you very much for inviting me to talk. And I feel like I'm with fellow Brummies because I'm actually a Brummie myself originally. So it's nice to be presenting to you all. We run a day case pathway as a sort of default pathway in our unit, and I'm going to tell you a little bit about, I will just touch on the national picture, although Rebecca's probably covered most of it. And I'm interested to see that you can see it by sight now, actually, I didn't know that. Just touch a little bit on change management, because I think it is just important to know a few principles of this if you're trying to change pathways. Have a look at our pathways, have a look at patient selection for day case TURBT, and then just touch on some results from our unit. So in terms of the national overview, as Rebecca's quite rightly said, GERFT have put a high onus now on day case pathways, and TURP, TURBT and ureteroscopy are all involved in that. And it's considered to be a high volume, low complexity procedure. And if we look at the workforce reports, we can see that we do about 40,000 in England per year, so massively higher than really any of the other operations apart from ureteroscopy. And the reason for this is that bladder cancer is a highly recurrent disease. So these patients will have a high number of repeat procedures over many years. And this has quite a significant impact on the patient with repeat admissions and repeat hospital visits. Has a high carbon footprint, and there is some work being done by GERFT at the moment looking at day case carbon footprints, which are better than inpatient carbon footprints. And obviously it's a highly costly disease to the NHS. So anything we can do to improve that patient experience is good. GERFT have produced this, which is a Bladder Cancer Academy document, and in this they describe day case TURBT pathways. So if you haven't seen this and you're thinking about instituting day case pathways, it's a really good practical guide to help you. And there's other advice out there. So the British Association of Day Surgery have lots of really good advice on their website, particularly in terms of patient selection, if you need to be talking to your anaesthetist about what are the right patients for this. And they've produced this document, which is a joint document, consensus document. And obviously with our COVID elective, or not elective in this case, but cancer backlog, day case rates are really good. So change management, I don't think you need to know huge amounts, and I'm not going to talk huge amounts about this, but I just think if anyone's trying to drive a change through in their unit, it's really worth knowing a little bit about this, just in terms of how you can actually deliver this on a practical level. And I have been involved with Olympus writing a how-to guide about day case pathways for TURP and TURBT, and you should be able to get that off your local rep. But in that, I talk about change management, what the drivers are for change, the benefits of a day case pathway, which stakeholders you should be trying to involve right at the start, a bit about pathway mapping, and then talk about some potential challenges. And I've just taken a few little excerpts from that to share with you today. So what are the current problems? So why would you want to switch from an inpatient to a day case pathway? Well, one of the main drivers is that there is a lack of inpatient beds in most hospitals, and this unfortunately leads to high cancellation rates, even for cancer procedures, although obviously they do get prioritised. And we're generally not meeting cancer targets throughout the UK, and certainly, and I'll just show in a minute some data from Model Hospital to prove that, but certainly this will have an impact on it. And obviously recurrent inpatient admissions for our bladder cancer patients leads to potentially a poor patient experience. So just looking at some Model Hospital data, whoops, I think I've gone a bit too fast there, we can see that 11.8% of our bladder cancer patients are currently achieving the treatment 62-day pathway. And that's not great. So I think anything we can do to improve or decrease the number of cancellations will improve that number. So what are the reasons for changing to a day case pathway? And these are really what we call the drivers for change. And these need to be, when you're implementing a change, the main vision or the main drivers behind your team. So obviously reduced inpatient admission time, patients being able to recover in their own bed and at home. Reducing the need for inpatient beds, which will increase your hospital flow and efficiency, decrease your cancellation rates, and hopefully decrease your waiting times, and overall lead to an improved patient experience. There are potential challenges or barriers whenever you're instituting a change, and I think it's important to try and look at that right at the beginning, to try and identify where your tricky areas may be and try and tackle it right at the beginning. And these are some of the things that people come across generally when talking about a day case TURBT pathway. So some of it may be colleagues not wishing to change, they've always done things in a certain way. Some of it may be lack of a daycare unit, patients not thought suitable for day case, maybe by the anaesthetist or the surgeons. Irrigation after TURBT is quite a big one, and I'll talk about that later. Being able to give mitomycin post-operatively. Possibly lacking a TWOT clinic might cause problems, and also you need to manage staff and patient expectations regarding these pathways. So I'll talk a little bit about these as I talk about our pathways and what we've done to try and overcome these challenges and barriers. So we have, just to explain sort of what we have in our unit, so we're quite a big unit. I think it's actually 25 now because we've just recruited. But we have a lot of consultants and a lot of registrars who are part of our non-muscle invasive bladder cancer team, so they may be involved in doing the flexes, but it's led by 3 of us. And so we keep quite a tight sort of oversight over our bladder cancer patients as a whole. And I think that's quite key when you're talking about day case TURBTs, because you need someone leading and driving on this. And TURBTs are not really procedures that should be best done kind of on the end of a list, so 2 laparonephrectomies and then a TURBT. They're ones that really should be having some thought put behind them and with someone who's managing them on a regular basis. So it's just really to have a think about that within your hospital, and I think it is quite useful to have a non-muscle invasive bladder cancer lead who can drive this through as part of the pathway. That's just some of our team there. So we start, as probably a lot of people do, start seeing patients in the one-stop clinic, and that's where we make our diagnosis. And it's at this point, if you're considering a day case TURP pathway, that we're managing our patient expectations and our clinician expectations. So when we give them the leaflet and the information form about the operation after diagnosis, they will have day case written on them. We then have an electronic waiting list form with a specific bladder cancer area to it. That has day case by default as it, and we collect a lot of different information about the bladder cancer so we can plan their operation. But one of the key things here is that it's day case by default. We then have a weekly review of all of our new TURBT listings or recurrent TURBTs by one of our bladder cancer consultants. And we check a number of different things and decide where they're going. But one of the things we do check is that they've been listed as day case. And if they haven't, we would go back and challenge might be a strong word, but maybe just ask the person who'd filled it in why. And the reason for doing this partly is because we think it's the best thing for our patients. But we have quite a relatively high turnover of our registrar population. We have fellows as well. We have quite a few of them, there's 15. And so not all of them work within the bladder cancer team, but quite a lot of them do the one-stop clinics. And so it's just really trying to manage all of that. And they may have come from units where people have inpatient TURBTs. So it's really just a bit of education around that as we go. And then on the day of the operation, so we don't have a day case unit, so all of our inpatient and day case patients are managed through the same structure. So we have something called Medi rooms, which are rooms that are next to our theatre complexes. The patient comes into the Medi rooms on the morning of their surgery, and they're allocated a specific room for them, which has a chair and a bed. They're seen by the nurse who's looking after them for the whole day. They're seen by the anaesthetist, the surgeon, and in there. And then they go from the Medi rooms to the operating theatre. We don't have anaesthetic rooms, so they're anaesthetised in the theatre suite. They have their operation, then they come back to the Medi rooms, the same room afterwards, will be looked after by the same nurse, and then will be discharged from their home if they're a day case patient, or may move to the wards from there, depending upon the plan. So whilst we don't have a day case unit, we do have a high rate of day cases. So in the Medi rooms point, we'll check with them the pre-filled consent form, which will talk about day case. We talk about are they able to go home with a catheter if that's needed, and check that they've got overnight care in place. And then during the theatre, we obviously have the WHO brief at the beginning of the list, and we want to manage the expectations of the theatre and the Medi rooms team at that point. In terms of this being a day case procedure, and at this point we normally have a discussion with the anaesthetist about what would be the most appropriate anaesthetic for them for their procedure, but also for them to be a day case. We have what's called bipolar plasma plus technology, which we perform all of our TURBTs under, and we think this is quite key or quite significant in terms of using bipolar and getting them home on the day, because it gives really good hemostasis. And there's a reasonable amount of evidence behind good use of bipolar in TURBTs. We give mitomycin in theatre, which again sometimes can be a barrier to getting people home on the same day. So we have it in a fridge that's within theatres and we'll prescribe it on the day. So we're lucky that we don't need to prescribe it beforehand, because I know some units have to do that, and that can be a bit of a barrier and can be a bit of a difficulty, but close liaison with pharmacy means that we're allowed to run this system. So we put a 16 two-way catheter in at the end if mitomycin is appropriate for that patient. The surgeon will give the mitomycin in theatre, and then they'll go back to their medi rooms and have it drained by the staff in medi rooms. And we train up all of our medi room staff to be au fait with mitomycin. The next question is irrigation. So we don't irrigate most of our patients, and I think again that's probably really helpful in trying to get our day case patients through, because we have an acceptable level of hemostasis. And I think probably not having this routinely is pretty key to helping with the day case pathway. And there's not many reasons why you would need it routinely, maybe in an incomplete resection, but we do consider self-irrigation if there are reasons why we may need to think about that. And that's what we've taken from our day case TURP pathway, which is where we give them IV fluids, furosemide and tranexamic at the end of the procedure. So that's just a consideration. And then I think the TWOC is also sometimes a stumbling block for some people. So we manage it in one of three ways. So either they have their catheter removed in the medi rooms after the mitomycin is drained and prior to them being discharged. If we feel that they need a catheter and they need to go home with a catheter, we would book them a urology outpatient TWOC within the next few days. And that's a TWOC clinic that's staffed by our urology specialist nurses in outpatients. Or we have a self-TWOC pathway, so for patients that it would be suitable for, and usually that's females or maybe younger males that we don't think have got prostatic issues, we would teach them to self-TWOC, and we have paperwork that goes with that. So they get told to TWOC on a specific day, and then our nurses will call them, so it's our urology outpatient nurses, call them a few hours later to check they're okay, and if there are any problems, then we bring them back to the our emergency hot clinic to have a catheter put back in. And we've just gone through our first 100 patients, and we haven't published the results yet, but I think only one needed to come back to the hot clinic. So we've got quite good criteria, I think, for selecting patients for that pathway, and it works quite well. How about selecting patients for a day case TURBT? Well, to look at this, we obviously have to liaise with our anaesthetic colleagues, and actually the British Association of Day Surgery have got some really good advice on this in terms of what they believe to be a good patient for day case surgery, and maybe in this case specifically for bladder tumour surgery. They don't have an age cutoff, so age is not a cutoff. Dementia is not a cutoff. So in actual fact, people who are frail and demented can quite often do a lot better back in their own home, as long as they've got appropriate support at home, because they're in their normal routines, and that leads to less worsening of their dementia. Whereas when they're in hospital, we've all seen that it can make people very confused, and they probably end up staying in for longer, unfortunately. So age and dementia aren't particularly cut-offs to not being a day case pathway. ASA is to some extent. So the BADS advice is that ASA 1, 2, 3 can be safely managed within a day case pathway. 4 and 5 not, but I have to say I think when we get to 4 and certainly 5, we would be considering whether a GA TURBT or a spinal TURBT is the right thing for this patient anywhere. We might be considering other pathways such as TULA, which one of your colleagues will be talking about later. And then how about diabetes? So traditionally, it's thought that diabetes would be a contraindication to a pathway. And actually in the GIRFT report, they found that in general, diabetics were staying in longer than other patients. It was one of the risk factors for being an inpatient for longer. And as a result of that, there's been some guidelines produced for people with diabetes undergoing elective and emergency care. And as part of this, they talk about day case pathways. And in actual fact, again, it's a bit like the dementia patients, but they do a lot better if they're in their normal routine, eating their normal foods. And so diabetes really isn't a contraindication to doing a day case procedure. Anticoagulation is the next thing. So anticoagulation isn't a contraindication, but it does need to be carefully managed. Most hospital trusts have appropriate anticoagulation guidance preoperatively with their day case surgery. And I think so with their preoperative colleagues, anaesthetic colleagues, but I think it is just something to be aware of for afterwards, because certainly when we've reviewed our data, this has been one of the patient groups that have come back in a little bit more than the others. And it's probably because there's always a balance in terms of restarting it versus the bleeding risk, which we all know goes on for about another 10 days. But they certainly need a very clear pathway for afterwards. And we do consider leaving them on Clexane for that 10-day mark and then restarting their anticoagulation, but obviously it's dependent on why they're on it. So not a contraindication, but does need to be carefully managed. Social factors. Now, this might be a contraindication. So all patients who have an anaesthetic need to have a competent adult with them for 24 hours afterwards. But that doesn't necessarily need to be one of their family or friends. There are some trusts that have partnered with outside charities or providers which provide a sitting service. So the Red Cross do this. And if you've got a separate room for these people to stay in, then they can go and sit with your patient for 24 hours afterwards, so that they can still be a day case. And then there are some trusts that have discounted short-acting spinals as needing someone to have 24 hours, someone with them 24 hours afterwards. But this does have to be agreed at your trust management level, but something that could be considered. And then the ability to manage a catheter. So not by any means all of our patients will go home after a TURBT. I think it's about 60% of ours don't. But there are some patients that are going to need to go home with a catheter, and obviously they're going to need to be able to manage it at home. Just because they can't manage it doesn't mean that you can't teach someone else to manage it. So it might be their wife, their carer, one of their family, but they might be able to manage it to enable them to go home. It doesn't necessarily mean that they can't come in, but there has to be a plan in place for that if they're going to go home. And then specific to bladder tumours, does size matter? Well, from our data, it doesn't really matter. The bigger tumours are likely to bleed more at the time of the operation. But I think if you use appropriate technology, appropriate techniques, appropriate hemostasis at the end of the procedure, there's no reason why these patients can't go home and be managed as a day case. But they are probably a little bit more likely to have a conversion to inpatient on the day. So to summary our criteria, our current exclusion criteria are being unable to socially stay overnight at home or have someone with them overnight at home, being unable to manage a catheter or have anyone that can manage a catheter at home, and ASA 4+, although as I said, we'd probably be thinking about a different procedure for them. So our inclusion criteria is essentially everyone else, and we do, as I've said, have day case by default for this. And there's various things that we've discussed, but we don't consider them to be exclusion criteria. So to talk you through a few of our results, so I just have to say thank you to two of my juniors who presented this at the British Association of Day Surgery this year. And Rebecca's shown you a bit about model hospital data, and you can get quite useful and good quality data out of this. So this was the results at the time. This is where we were sitting at the time that they presented our data. They looked through 100 consecutive patients. We had 79 which were planned as a day case, 15 that had a planned admission, mainly for social reasons, and 6 that were done as emergency TURBTs who were already inpatients. And out of this, we had out of our 79, we had 73 that ended up being discharged on the same day. So it's a 73% day case rate. And 6 of those had an unplanned overnight admission for the reasons I've put down there, so a variety of different reasons. So that is about a 7.5% unplanned readmission rate. And I think it's just important to note here that if it's not booked as a day case, it won't count in your day case rates. So even if it is booked as an inpatient, but they end up getting sent home the same day, that won't count in your day case data. And then whenever we talk about TURBTs, whenever I talk about TURBTs, I would always talk about quality indicators of TURBT. And I've just highlighted one of these here in our data. So we have high rates of muscle within our specimens. So we don't compromise on quality by doing day case TURBTs. And then how about the readmission rate? Because a lot of people talk about changing to a day case pathway. Does that increase your readmission rate? And actually, no, I haven't shown the model hospital data for it, but we're actually quite low for our readmission rate. So it's a 6% readmission rate due to urological issues. So in summary, I think there's significant benefits to a day case pathway for TURBT for both our patients and our hospitals. I don't think there are that many exclusion criteria for a patient undergoing a day case TURBT, and tumour size is not considered to be a cut-off criteria in our unit. We do think that the plasma bipolar technology helps in the day case rate, being able to give mitomycin in theatre and having no routine irrigation. And I do think you need to consider carefully the TOC pathway if you're starting this. But we believe that high day case rates can be achieved using this model. Thank you.